Dr. Manoj Chaudhary not joined yet.
I think Dr. Rajguru will take over. You can start it.
Okay.
Hi everyone, good evening. I thank everyone for joining us for today's lecture, and I'm privileged and honored to welcome my teacher, senior PGI Professor Dr. Dey, Pranab Dey, who is working as the Professor of Cytology and Gynec Pathology at the Postgraduate Institute of Medical Education Research. He's very popular. I guess everyone would be knowing him for his numerous publications, and he has authored totally 12 books in the field of cytology and histopathology. He has a vast experience in research and teaching, especially in cytology and gynec pathology, and has more than 400 research publications in various international journals. He is very popular amongst the postgraduates for his swiftness in reporting and for the kind in the way he approaches the way the residents can easily approach Professor Dey. So over to you, Professor, for the presentation.
Thank you very much. Am I visible?
Just make it full screen.
Yeah.
For
1 minute. One minute.
Yeah, just press that full screen button. Yeah. Absolutely fine.
Now,
Please start.
Am I visible and
Absolutely audible? Yes, sir.
Okay.
Please start.
Thank you. Good evening. Good evening to everyone. First, my thanks to Dr. Nadim, Dr. Raja Guru, and Dr. Radhika. I will take today 1 hour from your lifetime, and my topic is Effusion Cytology, problem-based approach. So I'll slowly progress of learning by seeing the problems, and this is the overview of the topic, and this is totally interactive topic, and I think that all of you will cooperate with me by giving a valuable opinion, comments. Let's start. There are several hurdles in the reporting of effusion cytology, and first thing is that, is it a benign lesion? Or is it a malignant? Most of the time, benign lesion cytology you may not predict or you may not assess the etiology. And in case of malignant, you have to see that and where is the primary site. So this is the overall approach. Let's see the first case. A 55-year-old man with massive ascites, and this is the first slide. what do you think? The most likely diagnosis. There are certain clusters of cells, and if you can see that this cell within the cell, so question number 1, your most likely diagnosis by seeing these pictures. So
We shall wait for a few responses.
yes,
Yeah, there are a few responses. Can we wait for some more time?
yes. So the options are no malignant cells in the effusion. That means reactive mesothelial cells only, lymphocyte-rich effusion, adenocarcinoma, and mesothelioma.
So far, there have been 4 responses, and all of them say it is no malignant cell in the effusion.
Yes. Yes. No malignant cell in the effusion. Let's see that. Yes, there is no malignant cells in the effusion. Sometimes the reactive mesothelial cells may have small aggregates, but if you look at aggregates, the cells do not show 3D clusters. Next case. So you can see that mesothelial cells, how do they look like? And if you see the window pattern in between, you can say that they are mesothelial cells. So no problem. Second case, a 32-year female presented with ascites. The cell, cannibalistic cells, single row of cells, small rows, mitotic figure, signet ring type of cells, again cell within the cell or cell cannibalism. So most likely diagnosis. Options are signet ring cell carcinoma, adenocarcinoma. A, B, C is lymphocyte rich effusion, D is reactive mesothelial cells. So we have the findings that discrete cells predominantly, occasional mitosis present, cell cannibalism there, and single rows of cells.
So far, there are 3 responses,
Yes,
and all of them have marked option D, reactive mesothelial cells.
reactive mesothelial cells. So it is absolutely right. And when we did that cell block and MOC31 immunostain, the cells clusters are negative. And lesson is that signet ring type of cells you may see in the benign effusion, cell in the cell or cannibalistic cells also you may find out, mitotic figures and rows of cells, they may be seen even in benign condition. So all the responses are right. Let's see the next. 38-year male presented with anorexia, weight loss and ascites. And these are the 4 representative pictures I have given. Most likely diagnosis, reactive mesothelial cells, lymphocyte-rich effusion, metastatic gastric carcinoma, mesothelioma. So I can wait for the response. Here in the meantime you can see the morphology, discrete cells, all, no clustering, round to oval cells, eccentric nucleus, then this is the overall picture, and higher magnification also I have shown. It's better not to see higher magnification because it may mislead you. So
far 3 responses, and
Yes.
all of them have marked C, metastatic gastric carcinoma.
oh, excellent. This actually, if you see that it is truly metastatic gastric carcinoma, known case. We did not have to do any immunostain here, and yes, it's right. And if you see the signature cells here, it is different. Nuclear morphology is totally different. Here the nucleus enlarged and pleomorphic. So all the responses are right. So signaturing cells you can see in this gastric adenocarcinoma, breast carcinoma, any mucinous adenocarcinoma, and even mesothelial cells. But you have to see the nucleus. Next, 35-year male patient had cough and breathlessness. Very easy slide. We'll go quickly to the next. This is the next slide. And these are the cells. So your diagnostic options: positive for malignancy, tuberculosis, acute inflammation, eosinophilic effusion. So if you see this representative slides, you can see this same slide also. So the diagnostic
So far, good responses for this particular case, sir. It is eosinophilic effusion, D.
Yes, it is very easy slide, and eosinophilic effusion we say when at least 10% eosinophils are present in the effusion slide. So there are etiologies of eosinophilic effusion. I will not discuss much. We think allergy is the common cause, but common cause actually most common is the repeated paracentesis, and if you do repeated aspiration, it may cause eosinophilia. So sometimes you can spot, question 5, you can spot here what are these findings. So any response here?
Can you take
one? Yes. Yes, Rajaguru. Yes, we can wait. Even it is spot, sometimes you may overlook if you are not careful enough.
So far, it has been a mixed response between option A and B, histoplasma infection and B candida.
Yes.
We have gone towards the interesting.
Okay. So these actually it is difficult sometimes, but in the microscope you can easily see. You may not see the hyphae, but the spore you can see, candidal spore, and here I think you can see here. Patient was in chemotherapy for acute myeloid leukemia, and here that similar findings. So we can wait for the response here again. Seeing the previous one, it may be easy to differentiate these two. Options are reactive mesothelial cells only, acute leukemia, metastatic carcinoma, and histoplasma infection.
Good response for this case, and all have marked D, histoplasma
Yes,
infection.
it is. If we see successively, it is histoplasma infections. It is uncommon infection. We usually do not see histoplasma, but if the patient is a immunosuppression patient, immunosuppressive therapy is going on, so patient may develop histoplasma, and here it is the spot, but there was no eosinophilia. I think we will not take any response because it's very clear-cut case. We can go to the next case. This is a microphilaria. So here also you will not take response. Sometimes you may detect Early cells. This is early cell, and this you can guess what it is. You may get this type of cells, and these are the vegetable material, and occasionally you can identify them very easily. They are epithelial cell ganglion. So this we are not taking any response. So overview of different benign lesions I have given you, and sometimes differential also. Now we will go to our more difficult area, which clinicians every day will ask you. And first case is a 61-year female with massive ascites, and you see these discrete cells, then occasional such clusters, then these are the clusters, and your diagnostic possibility. Diagnostic possibility, we are waiting for that. Negative for malignancy, atopia of undetermined significance, suspicious for malignancy, and malignancy. So step by step, 4 things we have put it. Here, this is this morphology. I can have seen this 20 objective, 40 objectives, higher magnification, then liquid-based cytology. So your options are these 4 options. Here we are going slowly, more difficult areas.
The responses have been predominantly suspicious for malignancy.
Yes, this is suspicious for malignancy. You are right, whoever has written. And when we did that mock 31, then we have seen that if you can see the strong membranous positivity. Mock 31 is the epithelial marker, cell markers. It identifies the epithelial cell receptors, and here you can see the very strong. And when we did the histopathology, this patient has a omental metastasis of ovarian carcinoma. So lesson is that immunocytochemistry on cell block section or other investigations are helpful in precise diagnosis of this category. And if you do this stain, you can diagnose it. Now, there are 2 articles, one from PGI Chandigarh, Dr. Radhika et al., another is Ashish Chandra et al. They have classified this. Let's know their diagnosis, then we'll go other cases. Non-diagnostic, number 8. Negative for malignancy, these are okay, but here problem starts. Atopia of undetermined significance. Atypical cells present, but there is not enough evidence to suggest these cells as malignant. Then suspicious for malignancy. Thus we are show atypical cells that are strongly suggestive of malignancy and malignancy. So problem is not A, B and E, problem is C and D. But D is that suspicious for malignancy. Let's see more cases. But before that, you should know that when you write that suspicious for malignancy, that is a microscopical diagnosis. And risk of malignancy, 82%. And atopia of undetermined significance, 66%. Let's see that. Now, question, with this knowledge, will apply it. Next cases. 56-year female patient presented with left-sided pleural effusion. These are the clusters, discrete cells. Cells are predominantly discrete, occasional clusters of cells. This cluster of cells shows mild degree, or you can say moderate mild degree of nuclear pleomorphism. Sometimes you may think this is mesothelial, sometimes epithelial. So we are waiting for the response of question number 13. And response same, negative for malignancy, atypia of undetermined significance, suspicious for malignancy and malignancy. Here you can see this cell morphology in this middle-aged or person, female person. So out of these 4, you have to choose one in your reporting time.
The responses are for ATP of undetermined significance. Option B. Yeah, most of them have selected.
Most of them option B. But if you see that, that is the subjective things. I agree that. But if you see that pleomorphism is quite much. Our routine reporting was suspicious for malignancy. The routine who have reported consultant.
There are 2 responses.
Yes, but when we did that cell block and MOC31, and that was very strong positive for MOC31. And the patient was further diagnosed as primary carcinoma of the lung. And Dr. Shumia et al., they have published their article, and they have shown that MOC31 is a very useful marker. And very strong membranous positivity, if we get, you can quite sure that they are malignant. So ultimately we had to report it as malignancy. And lesson is that all such atypical cases should have further ancillary test. If you have the option open, please do at least, if not possible 2 markers, at least 1 marker. And when we reviewed all the atypical cells, we have seen that when the single pleomorphic cells are there, small clusters of cells, atypical mitosis, long rows of cells, single row of pleomorphic cells. These are the commonly we have seen in atypical cells, that they present in these forms. Now, we will go to the next case. A 55-year male patient with massive ascites he presented. These are all the true history I am giving you, and different magnifications of these discrete cells populations. Clustering very minimal cluster, no pleomorphism, and these are the cells. Now again your diagnosis I have kept same type. Negative for malignancy, AUS, suspicious for malignancy, SFM, and malignancy, ML. Now, you have to choose A, B, C, D. And if you want to see the slide again, I can show that. Massive ascites patient had occasional this type of signaturing cells, but signaturing cells usually doesn't show much pleomorphism. Here again I am waiting for the response.
Option B.
Option B, atypia of undetermined significance. Reporting consultant reported it. 2 consultants in fact. Negative for malignancy. Because twice it came. Both the times negative for malignancy. Atypia of undetermined significance, truly speaking, yes, some amount of atypia you may or may not say, that is a subjective feeling. But the problem is not that. Problem is that the clinician strongly believed that there is malignancy. So we had the MOC31, a very strong positive cytoplasmic membrane positivity, and all these clusters, multiple such clusters were positive. And we did multicolored flow cytometry, where CD45, CD14 and IFCAM is the epithelial cell addition molecule, just like MOC31. And we gated those population of cells which are negative for CD45 and 14. And we have seen that very high percentage of cells are IFCAM positive. Normally epithelial cells should not be present. So these populations are so much, so we thought that this patient must have malignancy. And when the patient died of intestinal carcinoma, we retrospectively we did CDX2, which was strongly positive. So actually this was a intestinal carcinoma. And what is the lesson? Lesson is that you will miss this case. Even a malignant effusion may mimic benign, and if we have good resource and clinical suspicion is strong, then please do further test. That is the lesson. You may ignore also that lesson, because we are in the third world country, we cannot provide this. Yes, Nadim? Yes, please. Any comment?
No, sir, no comment. Somebody had just put on his mic, so we're just trying to put it off.
Okay. So, this case, again, a easy case I have kept. A 45-year female presented with huge ascites for 6 months. Aspiration yielded mucoid material. See, and the cells are there. Yes, these are the cells here, and occasional atypical looking cells, epithelial cells, not exactly mesothelial cells. So most likely diagnosis are 4: mesothelioma, metastatic adenocarcinoma, reactive mesothelial cell, pseudomyxoma. A, pseudomyxoma; B, reactive metastatic adenocarcinoma; C, D, mesothelioma.
Overwhelming response, it is option A, pseudomyxoma peritoneum.
Yes, it is a very clear-cut case. So it is good that people have recognized. Histopathology of the omental mass came, and these are the glands lined by completely benign-looking columnar mucin secreting cells. CDX2 was strong positive, nuclear positivity. PAX8 negative. PAX8 is the marker of genitourinary system, mainly female genital tract differentiation. PAX8 was negative, CK7 negative, CK20. So we thought that it is a primary, most likely GIT, gastrointestinal tract. And as you all diagnosed correctly, we will not discuss this much. But pseudomyxoma peritonei, usually you get suspicion when you see that very thick gelatinous mucoid material, difficult to spread on the slide. Histologically, disseminated peritoneal adenomycinosis and peritoneal mucinous carcinomatosis. But is that histopathology classification is not possible on cytology smear. At least we could not in our study classification of histology, classification by pseudomyxoma, pseudomyxoma peritonei, very difficult. So now if you see the malignancy, these are the panoramic overview I have given. When you see the 2-cell populations, 3D clusters, high NC ratio, multinucleated cells, signatoring type of cells, cannibalistic cells, many, not single, many, not ordinary mitosis, atypical tie-radiated mitosis, and sometimes abundant mucinous material, then squamous keratin pearls, samoma bodies, So these are the indicators of malignancy, morphological indicators, I am saying. So with this knowledge, we'll go to our next cases, but before that, we want to say that what are the features of metastatic adenocarcinoma? You may be all knowing that 3D clusters, cells with overlapping nuclei, cell block, holosphere, discrete malignant cells showing marked nuclear margin irregularities, multiple nucleoli, not single, multiple nucleoli, irregular nucleoli, and cells with vacuolated cytoplasm with nuclear pleomorphism. So these are the features of metastatic adenocarcinoma. So I have given you panoramic view of how to detect malignancy and what are the features. Let's see the cases. Okay, our next case, case number 16. Here you can see that 55-year patient has a dry cough and chest pain, and this is the one slide. Next, I am not describing the slides, but I am highlighting the laser pointer, the areas. So your diagnosis now. Reactive mesothelial cells, metastatic squamous cell carcinoma, small cell carcinoma, metastatic adenocarcinoma. If you see that, this is the Papanicola stain, and Papanicola stain has one benefit, that it has orange hue. So I have given enough hints in this simple case. So orange color cells are there. So diagnostic possibility straightforward. You may not need any special stain to confirm it. Okay.
The response is, yeah, uniform response. It is B, metastatic squamous cell carcinoma.
Right. It is a very straightforward. And the lesson is that presence of atypical squamous cell and fiber cells, orangophilic cells, are direct indicators of squamous cell carcinoma. So no discussion. And this is also spot. I am not taking, I think I will not take any response because it is a straightforward.
But still, I guess, we shall we wait? Yeah, but as you have said, we have got the options now. Yeah, the responses are there. It is metastatic malignant melanoma.
Yes, yes. It is such obvious case, metastatic malignant melanoma, and rarely you can see that. The moment you see the melanin pigment, and you can say that, but be careful. Sometimes there may be bleeding and hemocydin also, but this is not that color of hemocydin. See the Papanicola smear, and you should always see the nucleus. Here the nucleus is not visible, large prominent nucleoli, and this is that. Easy case. Now, many times you may feel problem. What is the problem? Problem is this highlighted cells. Who are they? Are they mesothelial cells or epithelial cells? So this is the very burning problem when you report effusion fluid. And if you have to solve the problem, you need cell block. Recommendation is that at least 2 epithelial marker and 2 mesothelial marker. Epithelial marker you can use BR EP4, it's a good epithelial marker, MOC31, and calretinin and WT1. Some people use D240, but at least actually calretinin is better marker. And there are other markers of mesothelial cells. So long list, but at least in your routine lab you can use this 4 stain. Now, if you have less resource, you can use MOC31 or BEREP4. Both are equally good, and one of them and calretinin or WT1. WT1 I will not recommend because many ovarian carcinoma also WT1 positive. So you can use calretinin. Now, like the universe, This is the galaxy that you do not know where is our planet, like where humans are still there. And now we'll find out unknown primary. That is another problem of effusion. And get long list. I'll not go through this list. Just a panoramic view in the table. It is absolutely impossible to remember. But I think basic idea we all have. And we'll go one by one, different cases. Case number 18. 51-year male presented with chest pain, fever, heaviness. One. Then these clusters, cells, cell within the cell, rows of cells, again vertebra-like appearance, vertebroid appearance, you can say, molding also. And this is the immunocytochemistry. This is cytokeratin 7, CD56 positive, synaptophysin positive, TTF1 also positive. So your option is, they are nothing but reactive mesothelial cells, metastatic small cell carcinoma, metastatic adenocarcinoma,
You've got the responses, and predominantly it is metastatic small cell carcinoma.
Yes, it is a straightforward case. If you know that CD56 and synaptophysin, actually synaptophysin is the beta stain than CD56 for the neuroendocrine marker as a neuroendocrine marker. So, yes, it is, you are right that it is a metastatic small cell carcinoma, and I have described that nuclear molding, small rows of cells, and these cells are CD56 positive, homogenin, synaptophysin, and TTF1 also many times. Let's see the other case now. These are the cell clusters. Female patient with peritoneal effusion, then the immunological malignancy, no doubt. If you see that these are malignant cells, but where is the primary? CK7 negative, 20 positive, CDX2 positive. So straightforward. TTF1 positive in lung carcinomas, it is not. Taxate, ovarian, means gynecological lesions, not. So most likely primary site.
Most of them have answered.
Yes. Yes, colonic carcinoma. So, yes, you are right, it is metastatic colonic carcinoma because it is positive for CD, CK20 and CDX2. And you may not have to do all the stains. According to your resource, you can ask the clinicians or clinical history, then you can choose your stain. Here, pleural effusion in an elderly female with cough and hemoptysis, malignancy, no doubt. CK7 strong positive, 20 negative, TTF1 positive, napsin positive, P63 negative. P63 is the squamous cell carcinoma of the lung, or squamous cell carcinoma of other squamous cell carcinoma also positive, but it is here negative. So here the diagnosis.
It's option A, lung. Most of them have answered option A, lung.
Lung.
Your option is lung, breast, ovary, and thyroid.
Lung.
It's option A, lung. That is the uniform response from most of the audience. I kindly request you to type in the message. Please don't unmute.
There is some internet issues at Dr. Dey's end.
Yeah, and I think those who have their videos on, please shut off your videos. Only the speaker should have his video on. I request all those who have turned on their videos to please close their videos.
Dr. Dey's internet is not working. His system is frozen.
Yeah, that's okay. We can, I think he will recover the thing.
He is logging in again.
He's logging in again. Dr. Rama Saha, could you please turn off your video? Dr. Rama Saha, can you please turn off your video? Yeah, Dr. Dey, yeah.
Audible?
Yeah, you're audible, but you have to share your screen.
Oh, now you are audible, sir. Visible, not visible?
Visible also, sir, but you have to share your screen.
Share with the screen. 1 minute. Present your entire screen. Share with the screen. Height. Is it okay?
Now visible, sir.
Okay. So I can go to that. Diagnosis is that straightforward. It is am I visible now? This lung carcinoma. Okay. Metastatic adenocarcinoma.
Everything is fine. Everything is fine. Go ahead.
Okay. So next case is very simple case. Here I will not take much option because our time is only 15 minutes. A 50-year female presented with huge ascites. The first slide, multiple this cannonball-like structures and total immune CK7 positive, 20 negative, PAX8 positive, WT1 positive, P53 positive, CDX2 negative. So your option is that mesothelioma, metastatic adenocarcinoma, from the ovary, from the colon, reactive mesothelial cell. So if you see that immunostain, CK7 positive, 20 negative, WT1 positive, PAX8 positive, P53 positive. So any response, Rajaguru?
Yes, sir. It's option B, metastatic adenocarcinoma from ovary.
Okay. So it is a straightforward metastatic adenocarcinoma. It was an ovarian carcinoma with omental metastasis, and as it is positive for this, so it indicates CK7 positive, PAX8 positive, P53, WT1. So most likely it is an ovarian carcinoma. So cannonball in effusion you may get in breast carcinoma, in mesothelioma, lung carcinoma, and ovary. So it is not a specific, you may get many conditions. At least these 4 conditions commonly we see these type of lesions. So if you see ovarian versus colonic, I can summarize that PAX8 positive in ovarian carcinoma, CDX2 in colonic carcinoma, CK7 in ovarian carcinoma, and CK20 in colonic carcinoma. So if you do this 4 stain, you are confident where it is from. Now, this is a 41-year female patient, presented with 10 centimeter diameter adnexal mass, right adnexal mass, ovarian mass with ascites. CA-125 level was 70, international unit, marginally high. Peritoneal was cytology was done at the time of removal of the adnexal mass. So this is one. This slide you can see 3-dimensional clusters. papilla-like clusters with fibrovascular core, Squamous body, mild pleomorphism. Your option is this: A, B, C, D. Mesothelioma, metastatic adenocarcinoma, reactive mesothelial cells, peritoneal implants from an ovarian tumor. So we have Squamous body, papilla-like clusters, irregular margin, papillary fibrovascular core, this mild degree nuclear enlargement and pleomorphism. So these are your option.
Almost everyone have responded as option A, peritoneal implants from ovarian tumor.
Oh, excellent. Because it is truth, but in routine reporting, we could not initially. Yes, it is right, and I'm really very happy because it's a very difficult diagnosis. Peritoneal implants from a ovarian tumor. Routine reporting, we thought it is a metastatic adenocarcinoma. But when you observed the histopathology of this is the borderline ovarian tumor, borderline serous ovarian tumor. So this is the comparison we have done. As you all have diagnosed correctly, so nothing to explain. You may know that regular margin, which when we compared that equal number of cases of borderline serous and serous carcinoma with ascites, we have seen that certain features are important, but it is very difficult of this diagnosis. Here, borderline serous, it's a very regular margin. And let's see that number 23, a 57-year male had hematuria for 2 months, and this is this picture. Cell vacuolated cytoplasm, large cells, nuclear pleomorphism, malignancy no doubt, multiple vacuoles, CK7 positive, Vimentin positive, Pax8 positive, CD10 also positive. You see that many of the cells, large cells. So your diagnosis. The primary diagnosis is from, or is it a mesothelioma, lung carcinoma, renal cell carcinoma, ovarian carcinoma?
Almost uniformly, everyone have answered option B, metastatic renal cell
Yes,
carcinoma.
option B. So, metastatic renal cell carcinoma, as you all have given option B, so you know, so we can go to the next case. And here you know that positive for Pax8, CD10, Vimentin, and CK, quite diagnostic of metastatic renal cell carcinoma. This is patient came with ascites in a 53-year male patient, multiple clusters, and malignancy no doubt, CK7 positive, 19 positive, 20 also positive, CDX1 negative. This is difficult, but when we see CK7 and CK19 both positive, with this option, you can eliminate then CDX negative, large intestine not.
I guess the audience are not finding it difficult, sir. They have all of them have answered option C, pancreatic or biliary region.
Okay, so pancreatic, I'm teaching or I am sharing with a very learned audience. Yes, they are right. Combined CK7-19 suggests pancreatic biliary carcinoma. So this is a pleural effusion, 36-year male, female, and multiple clusters. These are these clusters, discrete cells also there, and malignancy no doubt. GATA3 positive, ER positive, HER2 you see strong positive, and mammoglobin also positive. So most likely primary site, I can say here, I think everybody has made the correct diagnosis, because GATA3 is positive usually in the urinary bladder carcinoma and breast carcinomas, even some cases of salivary gland. So NES
The
B is the yes.
B and D breast.
Oh, sorry. This is my mistake. Actually, one should be colon. Sorry. So
Yeah.
B and D is
Everyone has answered as breast.
okay. So actually, these are everyone knows that. So I can go to the next one. This patient is right-sided pleural effusion. This is the first picture. Here, cells are here. Cell block also we have done. Calcifications. Question is not, first question is that, what immunostain will confirm the diagnosis? This is a difficult question, I have put it. And second is, what is your diagnosis, if it is positive? So, I have given a lot of hints here, but it is a difficult slide. I agree that, because if you see back, the patient is a 26-year patient, right-sided pleural effusion. Immediately you will say it is malignant. If you see that. So, what immunostain can confirm, and what is your diagnosis? Here I can wait, I think. So, if you see the arrow, I am trying to point something. I should not, but it is a difficult. The immunostain is cytoplasmic positivity. In fact, I have shown only one cluster, but there are multiple such clusters are positive.
Yes, sir. I guess most of them have answered it rightly. I mean to say they have answered it, and the predominant response is PTC, papillary thyroid carcinoma. Thyroglobulin is the IHC.
Yes, right. So you all know that now. Very good. Because routine reporting, it was a very difficult case until and unless we had the history. When we came to know the history of papillary carcinoma, we looked back to our cell block and we did thyroglobulin to confirm it. This is a case of, so this case actually very uncommon case. I am very happy that first time you have diagnosed these things. 27 is a pleural fluid in a 39-year-old female patient. Multiple clusters here. No, as the audience are very wise audience, I will not explain anything now. Your diagnosis, possible diagnosis. Again, same four. Metastatic adenocarcinoma, reactive mesothelial cells, suspicious for, yes, you can give suspicious for malignancy, mesothelial. So, this is the representative picture I have given to you. Many pictures, in fact, I have put it in together. And what is your possible diagnosis?
All of them have answered D, mesothelioma.
Oh my God. So without routine reporting, we thought it is a metastatic adenocarcinoma, in fact. But yes, they are right. All of them are right, because it was strongly positive for carnitine. MOG31 was negative. CK7 positive, CK56 positive. So yes, I really appreciate the audience. It is mesothelioma. And so the lesson is that, okay, I am not describing because all of you know that the cell look like mesothelial cells. That is the main thing, and the cells look like malignant cells. Next thing, and it may mimic adenocarcinoma until and unless you do whole immunostain, but you have diagnosed correctly without immunostain. That is a really great thing, and it is very difficult in fact. And these are the markers. I am not describing much, but newer markers are BAP1, BRCA1 associated proteins. Gene is well preserved in the benign mesothelial cells, and mesothelioma, it is lost. Now, here most likely diagnosis, 2-year-old child. Here I am not taking any response because out of this it is straightforward. When you see in a 2-year-old child and a renal mass, it is definitely Wilms tumor. Yes, it was a Wilms tumor. We took the history, it was a Wilms tumor. So no response. So lesson is that renal mass in a child with predominant round cell, we should think of Wilms tumor. Here the most likely diagnosis, it is 2 years back the patient came, a 12-year-old male, operated testicular mass. So obviously it is, again I am not taking any response because it is a very straightforward, I think. Because testicular mass, so.
So I guess the audience have got your vibes because they are very swift like you. All of them have answered C. Before you could just tell them to answer, they have all answered as C.
Okay.
Germ cell tumor.
So germ cell tumor. Okay. Now with this, I will come the areas where you get only lymphocytes. I think many times you face these problems. 60-year-old male, right-sided pleural effusion, and this type of lymphoid cells. Here you was stuck. Without flow cytometry, you cannot say that what it is. So this is the flow cytometry which we have done. Predominant CD19, lambda, or many cells are lambda, absolutely no kappa. So light chain restriction, CD523 both positive, many cells, CD19 positive population. So your diagnosis is lymphocyte-rich effusion, CLL oblique SLL, tuberculosis effusion, acute leukemic infection. The cells, acute leukemia, the cells, you can see that whether they are telling or not. So I think the audience can write here.
Yes, sir. Yes, this B, option B.
B.
Most of them,
Yes.
all of them have chosen
So
option B.
all of them are correct. Yes, they are. Now we have little time. I'll not take any response now. Another only 4 cases are left. So flow cytometry is essential to differentiate this lymphocyte-rich effusion, whether they are leukemia or lymphoma or not. And light chain restriction, here there is light chain restriction and CD19 523 positive, CD523 dual positive indicates that they are CLL or SLL. So again another case, similar type of history with a lot of lymphoid cells, and here also you are stuck. And when you see that, you can see that I will not take response, but you can see that main B cell population, CD20, CD19, no light chain restriction, CD3 also positive. So obviously this is a lymphocyte-rich effusion. Okay, so flow cytometry, no light chain restriction, so you can stay. Here, if you see that, here also I am not taking any response because we are short of time. You can see here, the most likely diagnosis here, the cells, immature looking cells are TGT positive, dual positive of CD48. Dual positivity CD48 usually indicates a lymphoma process of T-cell lymphoma, and it is also when TGT positive, you can safely report this as a non-Hodgkin lymphoma. T-cell lymphoblastic lymphoma. And here also we'll quickly go through this. Again, another case. You can see that lot of immature looking cells, and here also, if you see that dual positive CD4, CD8, and CD38 positive, CD4, CD7, mainly T cell. So it is a T cell NHL. And here, this patient came with a 55-year-old female. I'll take another just 3 minutes of pleural effusion. And here you can see that the most likely diagnosis, we can take the audience's response. Lymphocyte-rich effusion, metastatic small cell, plasma cell tumor, mesothelial cells. This patient has a back pain, and immature looking cells. So any response, Rajaguru?
So far, it's option C, plasma cell leukemia.
Yes, it is also right, good. So it is a very uncommon condition, not very common plasma cell tumor. But if you know the history, but here without much history also patient says that it is, our audience says that they are plasma cells because of typical nuclear morphology. And so here you can summarize our findings that in the male lung carcinoma more common, lung more common primary in pleural effusion, breast common primary in female, in ascites, GIT more common in the male, and gynecologic malignancy more common in the female. Hematologic malignancies are more common in child. In case of malignancy, I am saying, and primary sites. If you take a good clinical history, that is actually is enough, and radiological imaging. So it will give you a lot of information. And during this time, you can take the centrifuge and cell pellet. You can do cell block and all the things you can do, molecular test. And ancillary techniques we have not will not discuss much, because in the process I have discussed all the ancillary technique. Only thing that malignant mesothelial cells and benign mesothelial cells we can detect with the help of multiple states. Very difficult morphologically, but strong membranous GLUT1 positive positivity, EMA positivity and negative desmin, strong nuclear P53 positive, BAP1 negative was found in mesothelioma. So these are the features. Now, if we see that all the molecular tests can be done, there is a very good article written by Dr. Shomya. Here we can go all the molecular tests. This is the approach. I am not going in details because the time is short, but you can do PCR, next generation sequencing, and here how you will approach we have highlighted. So in summary, sorry I have taken 6 minutes extra, a careful microscopic examination, very important, with a good clinical history. You can do immunocytochemistry. It is more mandatory nowadays, because most of your problems you can solve. You can have to do flow cytometry if it is a if there is a confusion of lymphocyte-rich effusion versus leukemia lymphoma, or in suspected lymphoma cases, multicolored flow cytometry also very helpful. But one very important thing is coming, that is effusion fluid will be a future source of liquid biopsy, and lot of information you can gain. And this I have taken the cases from my books. Thank you very much. This is night time, and winter is coming. This is the nice aurora boreals in the northern hemisphere. I think night is slowly approaching, and I should finish our discussion here. Thank you very much.
Congratulations, Pranab.
Thank you.
Initially, I missed because of YouTube failure, but as I remember, in 2006, I quoted very few pathologists, cytopathologists has gone beyond morphology, and Pranab is one of the pioneers who has gone beyond morphology. Today, what was encouraging to me, our junior pathologist, Pranab. India is safe. So many experts, junior pathologists and PGTs that Radhika, I reassure you that our population is safe with such good diagnosticians who has joined today in Pranab staff. Thank you all.
Thank you very much. Any comments,
Sir,
Dr.
there are
Radhika?
few comments.
Yes.
Yeah, there are a few comments. Dr. Dr. Malik has commented, Pranab Da puts everyone at ease in whatever he does. Classic Pranab Dey, keep things simple. And
Thank you.
Dr. Bakul has messaged, lucidly explained, high quality photomics. Even a hematopathologist like me understands this. So,
Thank you very much.
There are so many appreciations and reviews for your lecture.
Actually, one thing to say that audience are more wise than me, and they are really very, very good. They diagnose all the difficult cases, which we have scratched our head. We could not diagnose in routine reporting.
Thank you, Dr. Dey. I am Dr. Amita Giri.
Yes, madam.
Yes. Thank you so much.
Thank you.
Thank you.
Vijay, this side, sir, it was really a wonderful presentation, sir. It was so lucid, and you have explained the things in such a simple way that everyone must have understood, sir.
Thank you.
Sir, Tushar Pandey here. Sir, amazing session. Thank you so much. Great to see all the professors again. Thank you so much, sir.
Hello, hi, Pranab Da.
Yes. Yes, Dr. Malik. Meanwhile,
Hi, Pranab Da. It was an amazing presentation, easy and classic Pranab Da, as I have mentioned already. And what I would like to request you and the organizers in the future to organize a talk from you on the ancillary techniques, because I don't think that there are too many people in the country who has worked on the ancillary methods for the last 2 decades on pleural effusion, on effusion cytology as you have, and we would really love to learn from your experience. I still remember your first thesis on DNA aneuploidy that you did with Dr. Indranil Saha, the late Dr. Indranil Saha, which was published even before he completed his MD. And then there is so much of work I see coming up from your lab on MOC31, and you have used flow cytometry on immunohistochemistry, and that's some amazing work, and we would love to learn from you. So in the future we would like to have a talk from you on the ancillary methods.
okay.
Thank you very much. Congratulations on a wonderful talk.
Thank you for your great comments.
It was truly a wonderful lecture, sir. I must say, sir.
For your valuable time and also showcasing what is the real world. I think what Dr. Dey showed to you is what is actually happening in our routine reporting. Dr. Dey is not something that came out of any project or anything. But I must say this is what is happening day in and day out. So I think ancillary techniques have really evolved, I would say, over the last decade, and it is so routine now for us to do the cell growth and IST and also the flow and any required effusions that I think if there was more time, then more cases could have been shown. But what has been shown gives a feel of the snapshot of what is happening on a day-to-day basis in PGI. And thank you so much, Dr. Dey, for showing this wonderful collection of cases. Thank you very much.
Thank you. Thank you very much, Radhika.